Good afternoon. I am Mabel Wagaran from CDC's Office of Public Health Preparedness and Response, Division of Emergency Operations. Thank you for joining us for today's Emergency Partners Information Connection webinar titled Protecting Pregnant Women and Babies During Public Health Emergencies. Today, we will hear from CDC's Sasha Ellington and Kara Powen. If you do not wish for your participation to be recorded, please exit at this time. You can end continuing education by completing this webinar. Please follow the instructions linked in the invitation you received. The course access code is EPIC 0822 with all letters capitalized. To repeat, the course access code to receive continuing education is all in caps EPIC 0822. Today's webinar is interactive. To make a comment, click the chat button on your screen and enter your thoughts. To ask a question, please use the Q&A button. The Q&A session will begin after both presenters have presented. We will now transition to our presenters, Sasha Ellington and Kara Powen. Sasha Ellington has been an epidemiologist at CDC since 2006. Primarily working in areas of infections during pregnancy and emergency preparedness and response. Ms. Ellington led the maternal health team for CDC's 2014 Ebola response and subsequently led the emergency preparedness and response activity in CDC's Division of Reproductive Health. She served on the Pregnancy and Birth Defects Task Force for CDC's 2016 Zika virus response, and led the domestic Zika pregnancy and infant research and surveillance team in the Division of Congenital and Developmental Disorders until May 2018. Ms. Ellington recently started as the Emergency Preparedness and Response Team Lead in the Division of Reproductive Health. Thanks for joining us, Sasha. Kara Powen has been an epidemiologist and health communicator with CDC's Division of Congenital and Developmental Disorders since 2008. From 2016 to 2017, she served as the communications lead for the Pregnancy and Birth Defects Task Force for CDC's Zika virus response. In this role, she led efforts to translate complex scientific guidance into resources and information for healthcare providers, pregnant women, and families. Prior to that, Ms. Powen deployed to Sierra Leone to support communication activities for the Ebola prevention vaccine trial, STRIVE. Thank you all for joining us today. Thank you, Sasha, and thank you, Kara, for joining us today. We may begin.
Thank you for that introduction, and good afternoon, everybody. Here's an outline of today's presentation. We will discuss the impact that public health emergencies have on pregnant women and infants. Then we will highlight two public health emergencies, the H1N1 pandemic and the Zika virus outbreak, and how they uniquely affected pregnant women and infants. Lastly, we will provide some tips and resources for ensuring the needs of pregnant women and infants are addressed during public health emergencies. Next slide. First, we are going to discuss the impact of public health emergencies on pregnant women and infants. Next slide, please. I want to be sure we're all on the same page first when we discuss public health emergencies. During today's presentation, when we refer to a public health emergency, this can include large-scale natural disasters, man-made disasters, and significant infectious disease outbreaks. Natural disasters include hurricanes, earthquakes, wildfires, and even events like Fukushima. Man-made disasters may be intentional, like September 11th and the 2001 anthrax attacks, or unintentional, like the Flint water crisis. Recent significant infectious disease outbreaks include the 2009 H1N1 pandemic, the Ebola outbreak in West Africa, and the Zika virus outbreak. Next slide, please. Pregnant women are cited as populations with special clinical needs or at risk in the 2013 Pandemic and All Hazards Reauthorization Act, or PAPRA. So what makes pregnant women at risk? Well, we know that for some infectious diseases, there's a disproportionate burden among pregnant women. For example, pregnant women may be at increased susceptibility compared to non-pregnant women for diseases such as malaria, listeria, and HIV. Pregnant women may be at increased risk for severity of disease once infected, such as influenza and measles. Additionally, some infections in pregnant women may increase risk for adverse pregnancy outcomes, such as Zika virus infection during pregnancy. We know less about the effects of disaster on pregnant women and reproductive health outcomes. Of the studies that have been conducted, findings have been inconsistent and methodologies have varied widely. However, studies suggest that disaster exposure may be associated with poor reproductive health outcomes, including preterm birth or low birth weight infants, increases in pregnancy complications, increase in psychological stress, separation from family and other support systems, possible exposure to contaminants, and loss of access to healthcare and medications. We lack surveillance on pregnant women affected by disasters. This is partly due to pregnant women comprising about 1% of the general population at any given time in the United States, which makes it difficult to collect meaningful information about them using traditional population-based post-disaster sampling strategies. Next slide. While our focus today is on pregnant women and infants, I would like to briefly mention that postpartum women are also uniquely affected by public health emergencies, though the literature is even more scant than for pregnant women. During a public health emergency, there may be reduced access to reproductive health care, including contraception, for women of reproductive age, and this may be particularly important for women who have recently given birth, as was noted after Hurricane Katrina. Other factors that have been noted include lack of access to well child and acute care, effects on infant feeding for both breastfeeding and formula feeding, a loss of infant care supplies, an increase in psychological stress, and separation from family and support systems. I'll now turn it over to Kara to talk about exposures during pregnancies and experiences in recent public health emergencies.
Thanks, Sasha. As Sasha mentioned, emergencies present unique challenges to pregnant women, and potential exposures to the developing baby during pregnancy can impact infants and children as they grow. Oh, next slide, please. Listed here are some of the possible impacts of exposures during pregnancy. Some exposures during pregnancy, like Zika virus infection, can cause birth defects in infants. Other possible impacts of public health emergencies during pregnancy include small for gestational age and low birth weight, neonatal complications, prolonged hospital stay, and morbidity and mortality. For many exposures during pregnancy, we don't know the longer-term impacts, but possible outcomes include cognitive impairment, motor delay, behavioral issues, and educational attainment in childhood. Next slide. Next, we'll cover some of our experiences from recent public health emergencies and what we've learned, particularly regarding impacts to pregnant women and infants. Next slide. On this slide is a depiction of CDC's emergency response activation levels. From level 3, the lowest level of activation, to level 1, the highest level of activation. The EOC has only operated at a level 1 response for 4 emergencies: Hurricane Katrina in 2005, H1N1 pandemic flu in 2009, Ebola in 2014, and Zika virus in 2016. I want to draw your attention to 2 of these public health emergencies, H1N1 and Zika. We will be discussing these examples in more detail in the next few slides because of their impacts to pregnant women and infants. For example, H1N1 was the first time a maternal health desk was activated to respond to issues facing pregnant women. And similarly, the Zika response stood up the Pregnancy and Birth Defects Task Force to respond to these vulnerable populations. Next slide. So what did we learn from these emergencies? From H1N1 to Ebola to Zika, the public health and medical community faced a series of complex and unpredictable outbreaks. The recent Zika outbreak served as a reminder of the vulnerability of pregnant women and babies to emerging infectious diseases. In each of these emergencies, it was critical to provide guidance to frontline healthcare providers caring for these vulnerable populations. And these emergencies also highlighted the need to rapidly collect data to inform response efforts. Now I'm going to turn it back over to Sasha to talk about 2009 H1N1. Next slide.
Thanks, Karen. Now I will talk a little bit about pandemic influenza and specifically the 2009 H1N1 pandemic and how it affected pregnant women. Next slide. In 2008, CDC convened a meeting entitled Pandemic Influenza, Special Considerations for Pregnant Women to obtain input from experts and key partners to develop public health recommendations for pregnant women in the event of an influenza pandemic. Meeting goals were to discuss issues specific to pregnant women, identify gaps in knowledge, and develop a public health approach for pregnant women in the event of a pandemic. The meeting focused on 4 main topics: prophylaxis and treatment with antivirals, vaccine use, non-pharmaceutical interventions, and healthcare planning and communications. As you may recall, 1 year later, the first cases of pandemic H1N1 were reported. Next slide. On April 22, 2009, CDC's Emergency Operations Center was activated for H1N1. Less than a week later, the maternal health desk, staffed by the maternal health team, was activated. It became clear very quickly that pregnant women were disproportionately affected by H1N1. The second documented death in the US from H1N1 was a healthy pregnant woman at 35 weeks gestation. She presented with symptoms to her obstetrician on April 15, 2009. Then on April 19th, she presented to the emergency room with worsening symptoms, and an emergency cesarean delivery was performed. On April 21st, she developed acute respiratory distress syndrome, or ARDS. She began receiving oseltamivir on April 28th, and she died on May 4th. The H1N1 pandemic was the first time a maternal health desk was established at CDC for a public health response. Next slide, please. An early report summarizing cases of H1N1 in pregnant women in the US from the first month of the outbreak found that the admission rate for pregnant women was 4.3 times that of the general population. The same report also described the 6 deaths among pregnant women in the first 2 months of the outbreak. All were in women who had developed pneumonia and subsequent ARDS. This highlighted the need to promptly treat pregnant women with H1N1 with antivirals. Next slide, please. In a subsequent publication of data through December 2009, it was reported that 280 pregnant women with H1N1 in the US had been admitted to an intensive care unit, and 56 pregnant women died. 5% of all reported H1N1 deaths were among pregnant women. This is compared to pregnant women making up approximately 1% of the general population in the US. Only 1 of those 56 deaths occurred in a pregnant patient who received treatment within 2 days of symptom onset. Next slide. During the 2009 H1N1 pandemic, CDC established the pregnancy flu line. This was the first national influenza surveillance system among pregnant women. It was a short-term targeted program to monitor pandemic and seasonal influenza in pregnant and postpartum women. The pregnancy flu line consisted of a 24-hour consultation phone line for clinicians and health departments and an enhanced passive surveillance system for severe influenza in pregnant and postpartum women. It was operational for 2 years from October 2009 through September 2011. Next slide. Many lessons were learned about influenza and pregnancy following the H1N1 pandemic. It provided clear and consistent evidence documenting the importance of treatment with influenza antiviral medications in pregnancy and justification for treatment of postpartum women for up to 2 weeks following delivery. It also increased influenza vaccination rates among pregnant women, which served as a model for other vaccines during pregnancy. It renewed scientific interest and focused in a wide variety of pregnancy and preparedness issues. Kara will now talk about the 2016 Zika virus outbreak. Next slide, please.
Thanks, Sasha. Now I'll discuss the 2016 Zika virus response. Similar to the maternal health desk for H1N1, we stood up the Pregnancy and Birth Defects Task Force because of the severe outcomes observed related to Zika virus infection during pregnancy. The Pregnancy and Birth Defects Task Force aimed to reduce the risk and impact of Zika virus infection in pregnant women, infants, and children through the activities mentioned here, such as collecting critical information about the impacts of infection during pregnancy, providing technical assistance to state and local partners, educating various audiences about Zika prevention, providing assistance to clinicians specifically around Zika virus testing, and more. Next slide. With Zika, we started with some knowledge of the infection, but very little understanding of the consequences to pregnant women and infants. Therefore, very early in the response, we recognized the need to collect information about the effects of Zika virus infection during pregnancy. About 2 months into the response, we'd started building the framework for the U.S. Zika Pregnancy Registry, which collected information about pregnant women with any laboratory evidence of possible Zika virus infection in the United States, regardless of whether there were symptoms. In Puerto Rico, we set up a similar pregnancy registry, which was tailored to the needs in Puerto Rico. Enhanced surveillance was also set up in Colombia. We also expanded birth defect surveillance to collect information on birth defects potentially related to Zika, which complemented the data collected through the registry. The information collected through these systems helped direct public health efforts to mitigate the impact of Zika and guide recommendations for the monitoring, evaluation, and management of women infected with Zika during pregnancy. Next slide. So briefly, here are the two data collection systems for Zika in the United States and how they complement each other. The U.S. Zika Pregnancy and Infant Registry collected information on pregnant women with lab evidence of possible Zika infection in their infants and follows them to assess the impact of infection during pregnancy. Zika birth defect surveillance collected information on all infants with birth defects potentially related to Zika, regardless of congenital exposure, and helped refer these families to services in their communities. Next slide. So what have we learned so far? Since the Zika virus outbreak began, CDC established that Zika is a cause of serious brain abnormalities, microcephaly, and potentially other birth defects. We recognize the pattern of birth defects associated with Zika virus infection, which is called congenital Zika syndrome. We provided clues toward the level of risk from congenital Zika virus infection, level of risk of birth defects, and we identified that Zika infections during any trimester has been associated with birth defects in the infant. Next slide. The data we collected help inform updates to CDC's clinical guidance. For example, CDC updated the recommended testing algorithm for pregnant women to reflect accumulating data on fetal abnormalities that might be consistent with Zika virus disease, including microcephaly, intracranial calcifications, and brain and eye abnormalities. Next slide. The Zika response demonstrated the need to rapidly collect data for action, as shown in this model. Collaboratively with our state, local, and territorial health departments, we consistently collected information about Zika's impact on pregnancy and used the data to update clinical guidance. The data was essential to protect this medically vulnerable population, and these lessons can be applied to other known or emerging threats. In the case of Zika, the threat was an infectious agent, but this same approach can be used to monitor any exposure as it relates to mothers and babies, whether it's a medication during pregnancy or vaccine, or another emerging infection or public health emergency. Next slide. Now we'll discuss some of the tips and resources if you're working with these populations. Next slide. We'll start with some strategies to reach these target audiences and then discuss some of the emergency preparedness and response tools that are available. They include the post-disaster indicators for pregnant and postpartum women and infants, a pregnancy estimation tool, and an online training on the effects of disasters on reproductive health. Next slide. So typically during a public health emergency, you need to get information out fast in order to protect your target populations. And this sounds really intuitive, but it's important to remember to consider who you are trying to reach and tailor your messages to your audience. Also try to focus your dissemination on where you might find your target audience. So I'm going to use Zika as an example here. Our target audiences were pregnant women, families, and healthcare providers. For pregnant women, we really wanted to push Zika prevention and how they could protect themselves. For families, we wanted to make sure they were aware of medical and social services to help children. And for healthcare providers, we wanted to make sure they could educate their patients on how to prevent infection and that they knew the testing recommendations and clinical care guidelines. Next slide. And here are some ideas for how to reach pregnant women. You can share information at events where you think they may be present, such as health fairs, local food banks, women's shelters, WIC, or home visiting services. You can also provide communications materials to healthcare providers caring for pregnant women. Shown here are some of the materials and information we had available for Zika. So all the way to the left, you can see a Zika fact sheet. We had a YouTube video on ways pregnant women can protect themselves, such as wearing EPA-registered insect repellent. We had social media messages going out through the CDC channels. We also worked with Text for Baby, which is a texting service that sends health alerts and reminders to women during pregnancy, and Mother to Baby, which is an organization who helps respond to pregnant women when they are concerned about a particular exposure during pregnancy. Next slide. Similarly, for healthcare providers, we disseminated health alerts or advisories. We worked with national and local chapters of professional organizations such as the American College of Obstetrics and Gynecology and the American Academy of Pediatrics to help disseminate messages to their membership. And we use tools to help with implementation of the guidance. So as shown here, we have a testing algorithm. We also have a web-based app that we developed that tailors next steps for testing pregnant women based on a few questions in the app. And then sometimes just face-to-face outreach and education, it's what's needed, but having tools in hand can help get the message across. And now I'm going to turn it over to Sasha to talk about some of the other tools that we have.
Thanks. Moving on, I'll talk about a few additional tools that we have. First, I'd like to discuss our post-disaster indicators for pregnant, postpartum women and infants. This is a list of common epidemiologic indicators for pregnant and postpartum women and infants affected by disaster. These were developed over a 12-month period in which we convened a nationwide group consisting of 23 federal, state, academic, and other key maternal child health partners to identify or develop the epidemiologic post-disaster reproductive health indicators. The indicators are primarily to guide assessment and surveillance and affect public health interventions for disaster-affected pregnant and postpartum women and infants. Hence, whenever possible, the focus is on actionable items where the public health programs, interventions, and policy can be used or adapted to meet needs. The final overall proposed list contains 25 indicators and their 90 measures for pregnant and postpartum women and infants, and their accompanying set of questions. All are available online at the DRH Emergency Preparedness webpage noted on the slide. We do not envision that all indicators or questions should be used in every assessment or surveillance tool, but that the user can select what indicators are important and what aspects of the indicator need to be measured in their setting. We encourage our partners to use these indicators and measures and share their experience with us. Next slide, please. Additionally, when conducting other post-disaster morbidity surveillance, you can use the post-disaster health indicators to collect supplemental information on pregnant and postpartum women. We have a sample protocol on our webpage which shows how this can be done. So if you'd like more information, you should see the link on this slide. Next slide, please. I'd also like to take the opportunity to let you know about our pregnancy estimator tool. This tool is for estimating the number of pregnant women in a geographic area when there's an emergency. It can be used as a preparedness tool as well as for when a response occurs. The tool has been a valuable resource for us in many settings. It is also available on our webpage. There is also an Excel link where you can plug in the numbers to calculate the number of women in your area as well. And it calculates the number of pregnant women at any point in time. Next slide, please. So I'd like to briefly discuss how CDC's Pregnancy Risk Assessment Monitoring System, or PRAMS, has been used to collect preparedness and response data. PRAMS is a population-based surveillance system of women who recently delivered a live infant. There are currently 51 sites, representing 83% of all US live births. Since 2009, PRAMS has been used to collect data from new mothers on emergency preparedness in several states. Additionally, PRAMS has been used post-disaster to collect much-needed vital information on maternal behaviors and knowledge. For instance, there were supplemental questionnaires implemented to collect data on H1N1 and Zika. And PRAMS is currently collecting data to assess the impact of the 2017 hurricane season in areas that were heavily impacted. Next slide, please. Additionally, the infrastructure built during the Zika response can be used for future public health emergencies as well. First, from the vantage point of maternal exposure, we can prospectively collect information about women with a potential exposure during pregnancy, such as in the US Zika Pregnancy and Infant Registry. From the vantage point of infant outcomes, we can leverage birth defects surveillance to focus on rapidly identifying fetuses and infants with potential exposures during pregnancy. The third component used during Zika that could be leveraged for future public health responses was surge capacity for local health departments in the form of public health professionals. This component was a way to get boots on the ground and provide additional support to local health departments that were heavily impacted by the Zika virus outbreak. Some states are already leveraging this infrastructure to address the opioid crisis and the effects of non-essential exposure to opioids during pregnancy. Next slide, please. We also have a web-based training. It's titled Reproductive Health and Emergency Preparedness and Response. After completing this course, learners should be able to identify ways to effectively respond to the needs of women of reproductive age during and after a disaster. The target audience for the course is healthcare professionals, state and local epidemiologists, emergency preparedness personnel, and other public health staff interested in reproductive health and emergency response. Next slide. It's a web-based training. It's divided into several sections with supplemental learning materials provided throughout the course. There's a lot of helpful links and items you can download during the course. It takes about an hour to complete. It's offered through CDC Train, a comprehensive catalog of public health learning products. It can be found at the web address provided on this slide, and there's also a link to it through the Division of Reproductive Health's Emergency Preparedness and Response webpage. And continuing education credits are offered for it. Next slide, please. So to summarize, we know that emergencies are unpredictable and the spread of disease can happen quickly. Pregnant women and babies are uniquely susceptible, and preparedness related to these populations should be a priority. Next slide. Thank you, and we'll take questions now.
Thank you so much, Sasha and Kara, for that beautiful presentation. We will be taking questions right now. So our first question is from Beth, and she says, might such surveillance measures be used in massive wildfire situations?
Yes, if post-disaster surveillance or even currently disaster surveillance is going on, the reproductive health indicators could be used to collect information on pregnant women and postpartum women and women with infants during wildfires. So they could be leveraged for that. If probably best if there is ongoing surveillance, if it could be integrated into ongoing surveillance efforts to identify the needs of the women in that area.
Thank you very much, Sasha. And we have another question from Brand, and he says, is there an expectation for jurisdictions to use the pregnancy estimator during disasters?
No, there's no expectation that jurisdictions would need to use this. This would be specifically if you are trying to estimate the number of pregnant women in your jurisdiction. There may be several reasons why you want to estimate that. I know, during the Zika response, some jurisdictions developed Zika prevention kits for pregnant women. So that could be a use on why you would want to know how many or estimate how many pregnant women are in your specific geographic area. If you're trying to get a denominator for risk estimates, you may want to get that using the estimator as well.
Thank you, Sasha. And he's also asking, he says, also prior to disasters to facilitate response planning, can that be used?
Yes. I mean, it can be used for any reason why you would need to know how many pregnant women or estimate how many pregnant women are in your area. So it could be, for a non-response setting as well, if that's information that you're trying to ascertain. And it can be used primarily by getting information from census data, and you plug those parameters in and you get an estimate. And if you can't find the specific parameters, there are some guidelines on general ones that may be appropriate for the US at large.
Okay, thank you. And so there's another question from Dr. Rahul Dip. He says, He would like to ask how it can be integrated with surveillance at the airport and border quarantine centers, as it may also require pre-screening prior to the travel, so that intervention or prevention steps can be adapted.
That's a good question. I think it can be, you could integrate aspects of this into border quarantine centers, a lot of and surveillance at the airports. I believe there was a lot of communication materials specifically targeted for these populations during Zika, Ebola. During the Ebola outbreak, there was also a lot of surveillance being conducted at the airport as well. So the information was needed there too. Kara, did you want to add anything specific?
Yeah, I was going to chime in on what you mentioned about communication materials. I know they had a lot of communication materials at the airports and at the border quarantine centers to advise people traveling or to areas with risk of Zika and things they could do to protect themselves while traveling, or if they were planning to become pregnant afterwards. We were hoping to reach pregnant women before they were thinking about travel, because the recommendation was that they avoid travel to areas with risk of Zika. So hopefully they weren't traveling to these areas. But for everyone else, we did have a lot of communication materials to let them know how to protect themselves and protect people once they returned as well.
Thank you very much, Kara. We don't have any more questions right now. We're just going to give you some time to ask, send any questions that you have. So I'm going to read just one more. It says, in the event of a large disaster with emergency shelters in place, does the CDC have a stance on mother-to-mother sharing of breast milk in shelters, especially if infant formula may not be available or is limited?
I do not believe we have any policy specific to that, just that we would recommend safe feeding for the infant.
Yeah, I'm not aware of the CDC policy, but we can definitely follow up.
Okay.
Mm-hmm.
Thank you very much, Sasha and Kara, for this beautiful presentation. We have just one more question from Brandt. It's just coming in. Could you possibly demonstrate the pregnancy estimator?
I think it'd be a little difficult to demo right here, but I will say if you go to the link that was provided on that slide, it walks you through an example of how to calculate it. So within that, there's a PDF document that you can walk through that example of a fictional area. And then you can also open up and download the Excel spreadsheet that's on the webpage as well. And you can play with that and put numbers in there. And then if you have questions, you can feel free to contact us as well.
Okay, thank you very much, Sasha. So we have another one asking, has there been any research on the long-term effects of H1N1 immunization that was given almost 10 years ago?
I'm not aware of any specific research related to that.
I'm not either.
Okay. Thank you. Thank you again for joining us for today's webinar. If you have additional questions, you may email them to epic@cdc.gov. As a reminder, today's presentation has been recorded and you can earn continuing education for your participation. Please follow the instructions linked in the invitation you received. The course access code is EPIC0822 with all letters capitalized. Thank you again. Goodbye.